Fantastic. So thank you and welcome back. Great morning to start with. Lots of things to think about. And now we're going to talk about the health economic data for decision making. So I'm chairing this session with Dr. Natalie Cavajo. And Natalie is a health economist at the University of Melbourne School of Population and Global Health, and also is honorary with us here at MCRI. Her research focuses primarily on priority setting of health interventions in low and middle income countries using cost-effectiveness analysis. Her research further aims to incorporate equity and budgetary considerations into cost-effectiveness analyses of interventions to improve maternal and child health in low and middle income countries, particularly in relation to childhood vaccines. So I will hand over to Natalie. Thank you.
Great, thanks a lot, Fiona. And good morning, everyone. So the title of what I'm going to be talking about today is looking at the effect of COVID-19 on immunization budgets. And I'm going to give a spoiler alert right now. I'm not going to have a great quantitative answer on this right now, as you'll see. But I think hopefully I'll give you some things to think about. So just to start with some motivation on why immunization budgets are important. And why we should care about dedicated funding for immunization. We know that sustainable funding is a key need to ensure progress towards universal immunization coverage. And this is reflected in the Global Vaccine Action Plan. It's particularly strategic objective 5, which is to ensure that immunization programs have sustainable access to predictable funding. And also what you heard about earlier today, the Immunization Agenda 2030, Strategic Priority Goal 6, Objective 3, which similarly focuses on sustainable funding. And we also heard Dr. Sandhu this morning talk about the WHO regional framework, which also has one of the objectives of having sustainable funding. We know that national government commitments to prioritizing immunization funding and immunization programs is one of the key factors of successful immunization programs, and particularly increasing introductions of new vaccines and increasing coverage over time. And that is what you can see on the figure on the right-hand side of this slide here. That shows increases in coverage for some of the key vaccines from 2000 all the way to 2019. So what do we know about immunization budgets? Probably not as much as we'd like to at this stage. There was a really fairly recent study that was led by Ulla Griffiths from UNICEF that compiled Ministry of Health budget line items for immunization for 2016 and 2017 in 33 African countries. So this is the results from their study. They found that the number of immunization line items varied substantially from 0 in 4 countries to 42. With a median of 8 items. They also found that immunization donor funding was sometimes including and sometimes not included. So it was included in only 10 of the budgets. And importantly, there were huge differences between budgeted amounts and expenditures in the majority of countries. In terms of actual spending per child, that varied quite substantially as well. So you can see here immunization budgets per child ranged from $1.37 in the Democratic Republic of Congo to nearly $68 in the Central African Republic, with an average of about $10 US per child. In terms of the fraction of immunization budget compared to the overall health budget, that also varied quite substantially. So ranging from 0.04% in Madagascar to 5.67% in Benin, and the average was about just under 2% across the countries. So what else do we know about immunization budgets? There are some data sources that exist and have been used by others to look at trying to piece together what we know about immunization budgets. So there's national health accounts that exist. They're not all of the same quality and not all of the same availability, as you can imagine. There's the joint reporting forms for WHO UNICEF that looks at coverage rates of vaccines. There's the CMYP that we've heard about previously. And then there's also databases out of IHME that look at development assistance for health. So one recent study has pieced all of these pieces together. And the 2 main findings that I wanted to highlight from this recent study is first, government spending was the largest source of funding for immunization. And this is in contrast to overall health budgets. And the second, and I'll show on the next slide, I'll show you some graphs of this. The second point is that immunization spending has increased steadily over time, particularly on routine childhood vaccination as opposed to supplementary immunization activities. And you can see that here in these two graphs from their paper. So you can see on the left, this is broken out by the GBD super regions. But essentially what you can see is the top bar represents immunization specific spending, and the second bar represents total health spending. And what's in blue, I know the legend's probably too small for you to see, but the blue represents government spending. And so you can see in the majority of settings, majority of regions, government spending is the largest source of funding for immunization spending as compared to overall health budgets where the government spending is slightly less compared to out-of-pocket spending particularly. The graph on the right, you can see is total spending on immunization by financing source. And this shows a really nice trend over time. So this is starting in 2000, going up till 2017. So of course it does not cover the last few years over COVID, but you can see that steady increase in government spending, which is the blue portions, and development assistance for health has also increased. So that's that sort of pinkish bar as well that you can see. So we know that new vaccine introductions has a large budget impact. This is unpublished work that we did for 4 Pacific Island countries that was funded by ADB to help support their new vaccine introductions of rotavirus, PCV, and HPV in 4 countries in the Pacific. And this just shows the massive costs that countries face as they're rolling out new vaccines. This is showing a steady increase over time because the cost sharing in the first few years was such that governments slowly increased their share of funding for vaccine doses over time. But basically what our study showed was that introducing these new vaccines resulted in a doubling to a quadrupling of vaccine specific budgets in these countries in order to introduce these new vaccines. So what effect has COVID-19 had on our immunization budgets? I know I haven't showed you any concrete evidence of this, and I don't think any of that evidence exists right now. We do have a lot of evidence emerging on the impact of COVID-19 across other aspects of the healthcare system. So you saw an example earlier today from Dr. Hardeep that showed a whole slide with some of the effects that have been shown from COVID-19 on immunization coverage, on access to care, on healthcare workers, and a whole range of other factors. And we can only imagine, we can understand that this obviously will have a clear impact on our immunization budgets and our health budgets moving forward as they're more constrained following COVID-19. If we just look at COVID-19 doses, and Fiona showed a different example of some very similar data here. This is the difference between what high-income countries would have to spend in terms of increasing their health spending in order to vaccinate 70% of their population with COVID vaccines, compared to, on the right-hand side, the amount that low-income countries would have to spend, would have to increase their healthcare spending by in order to vaccinate 70% of their population with COVID-19 vaccines. And this is a huge difference, as you can see. And it's really important. This is not just immunization budget spending, this is total health spending. So just looking at the effect of trying to get COVID doses out to their populations, you can imagine the add-on effects to countries' immunization budgets and health budgets from everything else that's happened. And this is using assumptions of a wide range of price for COVID-19 vaccines ranging from $2 to $40 with delivery costs in there as well. There's also thinking about catch-ups for children that missed out on their vaccines during the COVID-19 pandemic, particularly early on in the early 2000s. You can see that sharp dip in coverage rates across different regions of the world, which did recover, but that means there's still a lot of children that missed out on their vaccines and currently might need to be caught up. And that's an additional cost for countries to go out and reach those children that are not the usual targets of our immunization programs. Are COVID-19 vaccines part of countries' immunization budgets at the moment. I think that's still unclear. We were in a very emergency mode when COVID happened and when vaccines started to be rolled out. There was also COVAX and regional support by development partners and other country governments. However, we're seeing a lot of countries enact booster doses, and that indicates that COVID-19 vaccines may be a recurring expenditure for countries and may end up requiring to be added to countries' immunization budgets. So we need more time, and we need more data and more research to investigate how funding cycles and how budgets have changed over time following COVID-19. And I will end with just this last slide. So strong budgets are just one part of the solution. Increasing funding for immunization is not the only way to increase vaccination coverage. It's one very important way, but it's not the only way. We need to think about reductions in vaccine prices, and Fiona has touched on this, preferential purchasing arrangements, and our first speaker this morning touched on that as well. Reductions in delivery costs, for example, through integration of services, they might lead to efficiencies in how services are being provided. There are other ways as well that we can improve on efficiencies and thus reduce costs. So even if budgets do remain stagnant, or if there's other competing demands for healthcare budgets, which we know there always is, and Mark is going to talk a lot more about that in his talk, we can look into other ways to improve efficiency. So I'm going to end with that, and I will introduce, there will be time for Q&A after Professor Mark Jitt goes. So hold on to your questions. And I will introduce for you Professor Mark Jitt. I know most of you who were here yesterday probably know Mark, but I will introduce him for anyone joining us today for the first time. Professor Mark Jitt is Professor of Vaccine Epidemiology and Head of the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. His main research focus is investigating the epidemiological and economic impact of vaccines and other infectious disease control interventions to support evidence-based public health decision-making. He works closely with decision makers such as the World Health Organization, country governments, and national immunization technical advisory groups in vaccine introductions. Professor Jitt is going to talk to us about how to prioritize new vaccines when budgets are limited. And I know for some of you, this will be a bit of a review, particularly our PhD students and master's students who were in our training workshop on the Tuesday. So think about really hard questions that you can ask Mark during his talk. Hold them for the end, and I'm sure he'd be delighted to answer them for you. Thank you, Mark.
Great, thank you, Natalie, for that introduction. Thanks for having me here. It's great to be here again. And yeah, PhD students, you've got 20 minutes to think of really hard questions for me to answer later. But really, I'm excited to talk about this because it is, I mean, I think Natalie, Dr. Carvalho, she set the scene really well in terms of, well, budgets which are already tight and getting even tighter. So how do we make these decisions about whether or not to introduce a new vaccine, how to prioritize vaccines, how to choose between different vaccine schedules, for instance, like we heard a lot about with regards to PCV this morning. That's what I'm going to talk about. And maybe I'll motivate this. I mean, I think in the previous talk, we heard a bit about DRC having maybe one of the smallest immunization budgets in the world. And maybe that's partly because it has one of the smallest healthcare budgets in the world. So let's think of a sort of thought experiment. Imagine that you are in the decision maker's seat here, whether you're the Minister of Public Health for DRC, and your entire department's budget is about $17 US a person. Not to single it out, I mean, there are many countries in this situation with low budgets and lots of healthcare needs. How would you prioritize the budget? I mean, it's very small, but it can still do a lot of good, right? So how would you make these decisions? And maybe one way that people might say is, well, why not look at the evidence? Maybe talk to WHO, talk to the World Bank and say, what is the best buy for the healthcare budget that we have. And in fact, there's a very classic study that the World Bank did about almost 30 years ago, I think, that looked at this question. They asked the question about what are the sort of essential healthcare interventions that every country should really consider putting in a sort of basic package of healthcare interventions, that no matter how sort of short the resources are, these are something that every country needs to do. And the way they did that was to look at a metric called the cost per DALY. Basically, what it does is it looks at a measure of how much you're paying for health. So I'm going to explain this in the next slide. If you're familiar with cost effectiveness analysis, this is revision. If not, really what we're thinking of is when we do an economic study, a cost effectiveness study, is we're comparing two worlds. Right? It's not like there are two worlds. There's one world where you introduce an intervention. It might be PCV vaccination. It might be, making antibiotics available for pneumonia. It might be cancer therapy. In another world, you don't introduce the intervention. That's so the world where you have it is on the right. The world you don't have the intervention is on the left. And basically, you're comparing these worlds and you're saying, which world would I rather be in? And you compare it from the perspective of the difference in costs. So in the world in the left, you pay something, you pay to treat the illness if you're not preventing it with a vaccine, right? In the world in the right, you're paying for the intervention, maybe the vaccine or maybe some other intervention which might decrease the burden of disease or help to treat people or so forth. And therefore, the cost of the illness decreases, but you have this additional cost of the intervention itself, like the vaccine. And then there's a difference in the world in terms of the health burden as well. So health economics is not purely about saving money. Health economics is about saying, how do we get the most health, the most value for our money? And in the world of health, its value is health, right? So if you introduce this intervention, you decrease the health burden. What happens if you decrease the health burden? Well, that means that, people are happier because they're healthier, right? People don't want to be sick. People don't want to die. And so you want to say, how much are we paying for each unit of health that we're buying? And so really what we have is a fraction. At the top of the fraction, we have the net cost. The net cost is the cost you'd pay if you have the intervention, you introduce the vaccine, minus the cost you'd pay without the vaccine, right? So you save money because you don't treat the disease, but you pay more money for the vaccine. So net, how much are we paying divided by how much health are we getting? It could be number of cases of the disease you avert. It could be, how many deaths you avert, how many life years you might gain, or people might use a metric like a DALY, which the World Bank used, or a QALY. And these are metrics which combine both the morbidity or disability associated with disease and the mortality, the deaths associated with the disease. So if people die, we count that. But even if people don't die, but they're in poor health, if people, someone survives pneumococcal meningitis, but they have sort of like long-term sequelae, they become deaf, or they have, they lose a limb or something like that, then that is a sort of loss of health throughout their life. So we calculate all those losses in health and in life, and we combine it in a unit called a DALY. And one DALY is roughly speaking, 1 year of life in perfect health. And so what we're saying here when we calculate the cost per DALY is how much do we pay to give a person 1 extra year of life in perfect health? And this group that the World Bank Commission looked at a whole range of interventions and said, well, these are some of the best buys you can have in health. These are the things that every country should do. And very high on the top of the list was something they call the EPI plus. Now, for vaccine people, when familiar with EPI, right? It's the set of vaccines that WHO has been recommending for decades, ever since the sort of late 1970s. So basically DTP, measles, polio, BCG, hepatitis B. And on top of that, they said add vitamin A supplementation for children. That package costs about $12 to $17 per DALY, which means for less than $20 US, probably more now because of inflation. But at that time, for less than $20 US, you'll give someone an entire year of life in perfect health. That's how good this intervention is. So this is, so the take-home message here is, well, EPI vaccines are one of the most cost-effective interventions. You hardly need to, do analyses for this. This has been well established. I guess the challenging thing is, well, every country should introduce EPI vaccines and maintain high coverage of EPI vaccines. They are such good buys in health. They give you so much health, so much benefit for so little money. But vaccines have changed, right? And I'm going to go through this quite quickly because I think Professor Russell talked a lot about this already, about how these new vaccines now that we have are much more expensive now. So the traditional, the EPI vaccines, these were cheap vaccines. You saw those graphs that she showed just earlier this morning. They're also against really common infections that every single person had, every child had in their lives before these vaccines were introduced, like measles. Everyone would have almost sometime in their life. Now, in the sort of since the 1970s, many new vaccines have been introduced, which is great. We have more options, more ability to prevent diseases that are killing people. But these vaccines are more expensive, and they're also sometimes more challenging to evaluate and deliver. So, you know, they're often not delivered just to infants like most of the EPI vaccines are, but we want to give HPV to adolescents. We want to give COVID vaccines and maternal vaccines to adults, for instance. So countries need to say, how am I going to deliver these vaccines? I need to set up new systems. The vaccines themselves are more complicated because, I mean, like we've seen with maybe malaria vaccine, which is against a really high burden disease in many countries, but the vaccine doesn't last that long. So the vaccine wanes. Same we've seen with COVID vaccines, the emergence of variants decreases the efficacy of these vaccines. And so these are some of the considerations that we need to make when deciding how do we choose which of these vaccines to introduce. Okay, and there's just the overall effect on the budget. So here's a very similar slide to what you saw this morning, just making the point. All the vaccines that WHO recommends, only the vaccines WHO recommends, the cost of that package to the lowest price available, the Gavi price, has increased 68 times since the year 2000. From 67 cents a dose to more than $45 a dose, which exceeds the total health expenditure per capita in lots of countries. So what's the solution? Do countries then have to forego these vaccines? Well, one solution that the global community came up with was setting up Gavi in the early 2000s. So, you know, the public-private partnership that buys vaccines collectively on behalf of the global community and then supplies it at very low cost or zero cost to some of the poorest countries in the world. But Gavi, as you know, the funding will start to sort of decrease as countries go to the transition from low income to middle income countries. And I think that is many of the countries in the, Western Pacific region have, and Southeast Asia region have either transitioned from Gavi funding or actually were never eligible for Gavi funding in the first place, like the Philippines, for instance. And so countries need to, as countries are making decisions about vaccine introduction, they need to consider other sources of financing as well. And in this slide, we think of actually, really thinking of two sources of financing. One is the external sources of financing, like Gavi funding, or like bilateral or multilateral aid that countries can get. But increasingly, as countries' incomes increases, they need to rely more on internal sources of revenue as well. For instance, well, general revenue, the general budget. But as you know, healthcare budgets are often squeezed. So another possibility is actually earmark taxes, and talking to some colleagues about talking about the sort of in some countries they call it the sin taxes, right? The taxes on alcohol and tobacco, which sometimes the Ministry of Health can ensure get diverted towards the healthcare budget, because these are sort of taxes on activities that increase the overall health burden. So in a sense, diverting them to improve the healthcare system is a way also to maintain a sort of steady source of revenue for healthcare. There are also other sort of financial mechanisms that countries start to consider as they start to finance vaccination themselves, like social health insurance, for instance, or some methods like user fees or private health insurance, which might be a solution to increasing coverage, but could end up being very equitable because only the people who can afford the user fees will then access the vaccines. Only people who have the health insurance because they're working, for instance, will be able to access the vaccine. So these aren't great methods that Gavi or the WHO recommends, because they can end up with vaccines only being accessible to rich people. And then we talked a lot about, well, revolving funds, pooled procurement, like what PAHO does, like what ASEAN is considering, revolving funds so that through the PAHO revolving fund, every country can have the means to access these vaccines, because there is this fund set up that also enables them to be able to access these vaccines. So that's on the financing side, countries thinking of the how do we finance these vaccines that we want to introduce. How about on the decision-making side? How do countries make the decision about which vaccines they want to introduce? And so what I'm going to start off with is maybe give an example from the UK, but I mean, during the economics workshop on Tuesday, we also heard many other examples from countries in the region about how they have similar systems or systems which might differ in some ways, but you know, also implementing the same principles of making decisions based on country values, based on evidence, based on economic principles. So to give an example of the UK, the UK's NITAG is called the Joint Committee on Vaccination and Immunization. And the NITAG, the JCVI, makes recommendations to the Health Secretary, basically the Minister of Health, about whether or not to introduce a vaccine. And the JCVI actually has a legal basis. So if the JCVI recommends a vaccine to be introduced, and that vaccine meets a number of criteria, including being supported by a cost effectiveness analysis, which shows that the vaccine is cost effective, then legally the Minister of Health has to introduce the vaccine. There is a right that people have to that vaccine if it's recommended by the JCVI. So that shows the importance of cost effectiveness analysis. JCVI is only allowed to do this if an independent cost effectiveness analysis is commissioned and it's shown to be cost effective. So this is usually done by the National Public Health Agency, the UK Health Security Agency, or formerly Public Health England. Sometimes it's done by an independent academic group, and then that's presented at the NITAG. And then there's a debate. The NITAG will often ask questions, check the assumptions, ask for additional scenarios, and if they're satisfied it's cost effective, they will then recommend to the Health Secretary for the vaccine to be introduced. The Health Secretary then directs the Department of Health to then open a competitive tender to ask different vaccine companies, like for PCV, to ask the GSK and Pfizer and any other companies to bid to supply PCV vaccines. And then how do you make that decision? I mean, the vaccines have different efficacies, different valencies. Well, that uses the same cost effectiveness analysis, but that is then turned into points in a tender system. So PCV 10 might get a certain number of points, PCV 13 might get a certain number of points. And that points are then weighted by the price that the companies charge. The companies are invited to give a bid about how much they'll charge. That is weighted by the value the vaccine gives. And then finally, an overall decision will be made after the sort of sealed tenders are open and they're weighted and the decision is made. And ultimately, in the cost effectiveness analysis, the prices have to be below a threshold for cost effectiveness, which is about £20,000 per QALY in the UK. So this graph illustrates what's really happening. So, well, okay. Oh, no, I don't really have a pointer, but anyway, the idea is if something costs more than £20,000 per QALY, what is going to happen is, let's say there's an intervention that, let's see, do I have a point? Okay, let's say there's an intervention that costs 20,000, that costs £30,000 per QALY. That's the dot at the top. What would happen then is, if to gain 2 QALYs, to gain 2 years of perfect health from that, the country will have to pay £60,000 per QALY. The UK will pay that. And they will, from that, because other interventions in the healthcare budget cost £20,000 per quality, they'll be losing 3 qualities for only 2 qualities they're gaining. So that intervention will not be considered cost effective. That's looking at the dot right at the top and looking at the red line going to the blue line there. If you drop right to the bottom, you see you lose 1 quality because you'll gain 2 qualities from that, but you lose 3 qualities. So overall, you lose 1 quality. However, if this intervention actually costs only £10,000 per quality, then to gain 2 qualities, you only need to pay £20,000 per quality. And that's the blue dot at the third blue dot towards the bottom. And if you look at the price P1, you look at the line going there, you say, well, you pay £20,000 per quality, you gain 2 qualities, but you actually lose 1 quality because you take out something else from the healthcare budget, which only buys you 1 quality because the average thing in the healthcare budget is £20,000 per quality. So overall, the country is healthier, you gain 1 quality. So with that threshold, £20,000 per quality, you can ensure that anything else you add to the healthcare budget, even if your budget is limited, it means that you overall gain health. Of course, this is not the only consideration. There are lots of other considerations that countries have to make when they want to think about introduction of a vaccine, for instance. For instance, there might be a vaccine that is more expensive than the threshold you set, but it's very equitable. The benefits of the vaccine go to the worst of people in the country, and therefore you might want to prioritize them. Or there might be, concerns about things like health security, for instance. Some countries are willing to pay more for a local vaccine, even though it's less cost effective than maybe a vaccine produced in another country, because they know that the supply will be guaranteed, even if there's, like a pandemic or something like that. So there are other considerations that countries might make, and this is just a universe of them. So I'm going to end just by with a few key messages. First of all, we know that new vaccines save lives. We've heard about PCV. I mean, the same for other new vaccines, rotavirus, malaria, HPV. But the cost and the complexity of these new vaccines is greater than the vaccines that countries have been using for decades, the EPI vaccines. And therefore, countries need to carefully consider both how they're going to be financed, and that might be from Gavi for the lowest income countries, but eventually even those countries need to consider sustainability of financing and what other internal and external sources they're going to use to finance vaccines. And second of all, cost effectiveness. If they introduce this vaccine, are they going to gain more health than will be displaced because of the budget for it? So lots of these new vaccines are cost effective. I'm not saying this because I'm saying these are not cost effective vaccines. There have been many studies on PCV, on rotavirus, on HPV showing they are cost effective in almost every country in the world, but each country will often want to do its own analysis using its own data for this. And obviously there are many other criteria as well. So I'm going to end here and happy to take those difficult questions at the end that people have been preparing.
There are no questions on the Q&A at the moment. Are there any questions from the audience? Yep, we've got one over there.
Thank you. It was super interesting. Catherine Satsky from MCRI. Very much not my area. So I guess I was just wondering, in sort of understanding the process, that the decision to introduce the vaccine is made kind of before the price is really negotiated. So how does that kind of impact the cost effectiveness analysis? And is there ever kind of a disconnect that the kind of assumptions of the price of the vaccine were incorrect and might have actually influenced that original decision to introduce?
Take it or shall I? I think that's a good point. So sometimes cost effectiveness analyses are done, but they use the sort of market price of the vaccine. And that's usually a higher price than countries can get if they are able to negotiate with the manufacturers. I mean, obviously, some countries have a better ability to negotiate than others, but to some extent, if countries have a good technical process, like a cost, economists who can do cost-effectiveness analyses, they're often able to get good prices from manufacturers because they can go to the manufacturer and say, we know what this vaccine's worth, give us a price that is, better than this, otherwise we're not going to introduce it. Countries which have a bigger population, also they have more purchasing power. So often smaller countries, it might make sense for them to, I don't know, like PAHO, countries in Latin America, they group together, and because of that, they have a lot of purchasing power. So because of that, PAHO gets the second best prices in the world, besides Gavi on vaccines. So that also gives a lower price for the vaccine. So I think it's important that when the analysis is done, it's not just saying, well, it's cost effective or not, but instead the analysis should say, well, at this price, the vaccine is cost effective. Anything more than this, it's not, and anything less than this, it is. Hope that helps. But sounds like Fiona, Professor Russell might have something to add or a question. Yeah. Yes.
Thanks. No, thanks for great presentations. Mark, I was just also interested now in what's happening in the UK with regard to COVID vaccine. Obviously, the decisions had to be made immediately for obvious reasons. And the vaccine was offered to, based on priorities, based on epidemiology, essentially. But now we're at a position where, do you think it'll come back to sort of more standard processes like cost effectiveness? We see in the Nordic countries now, they're not offering vaccine for anyone under 50 or unless you're high risk or whatever. So do you think that'll come back, or do you think it'll still be based on epidemiology and what we see with the immunology and hybrid immunity, or do you think the economics will come back?
I think that's okay. I think that's a great question. And that's a question that I've been asking and had quite a lot of dialogue about it. So sort of in the last few years, the vaccines that there were cost effectiveness analyses. We did some and so did others of these vaccines. And they showed that they were incredibly cost effective, but they weren't really used in the decision making because the JCVI and other bodies said, well, it's obvious that we need to use these vaccines and we want to use as many doses as we can get. And so they prioritize, it was more about which group would it be best to prioritize instead of maximizing health. And in terms of which vaccines to use, well, we started off with the Pfizer vaccine because that was the first to be licensed, and then UK had a whole bunch, a lot of AstraZeneca vaccines, and so those got delivered, and then more Pfizer came, and so it was just whatever arrived got sent out straight away. So, but now we're in a position where we're no longer in such a supply constrained environment, and where actually more decisions will have to be made in the future about, are we going to give additional boosters? So there has been discussion of actually this should be based on, regular cost effectiveness analysis. The second booster still wasn't. I mean, the reason for the cutoff at age 50, there has been sort of risk benefit analyses done around vaccines, and actually the threshold for those risk benefit analyses is extremely high. So I mean, I think a COVID vaccine on the whole will benefit virtually anyone who gets it, but because in these risk benefit analyses, the risk is weighted many more times than the benefit. So you have to save, you have to prevent you have to save many, many more lives than might be caused by the possible very, very rare but still existent sort of like adverse events from these vaccines. So because of that, there are certain age cutoffs that were set in the UK. I mean, other countries like the US have lower age cutoffs, but that's purely because of these risk benefit analyses. And for the second booster, like most of the country has already received the first booster, so it was felt that only the sort of highest risk groups would have so much benefit from another booster that it would be justifiable to give them. But I think in future rounds, quite possibly there will be cost effectiveness analysis. So thanks for that question.
Mark, Professor Jitt, and to all the questions. I know there are probably some more burning questions, but we're going to have to stop because we started a bit late. And we're going to move on now to a panel session. So I'll invite Professor Fiona Russell to come back.
Fabulous. So thank you so much, Natalie and Mark. That was terrific. And so now I'd like to invite the panelists to come down to the front. And we're going to have a chat about, from country's perspective, we had this morning about, just an overview of the data and the evidence around PCV and policy decision-making around schedule. So if the panelists could join me down the front, please come through. And we've also got panelists online as well. They should be made available, I think, too. Is that they're online? Oh, fantastic, there they are. So thank you. So also we've got Dr. Hardeep from Manila and Wipro, and we have Professor Kulkarni, wonderful to see you there, from Thailand. And we've also got Yin Yin from UNICEF in the Pacific. Oh, that's me. Okay, so, and then, so fantastic. So yes, this might be a little bit of a challenge, but we'll see how we go with this hybrid sort of setup and the Q&A and the chat, but we've got plenty of time. So, so first of all, we're just going to do introductions. And so we'll go around and just introduce ourselves, and I think I've already introduced myself, but just in particular in relation to your role in any vaccine decision making that might occur in your country. So we'll start from Dr. Tuya, if you could introduce yourself, thanks.
Thank you, Fiona. I'm Tuya, came from Mongolia. I'm a pediatrician working for the National Center for Communicable Disease on the project of the PCV impact study for pediatrician, for children, as well as the indirect impact of the PCV in adults. And I'm also a member of the NITAC of the country. Thank you.
Thanks, Tuya. Next, Professor Anna.
Hi, good morning, everybody. I'm Anna Ong Lim. I'm with the University of the Philippines, Manila, and the Philippine General Hospital. We are the National National University Hospital, and as part of the academic faculty there, I've been asked to provide inputs for the National Immunization Program on various topics, including PCV vaccines.
Thank you. Dr. Rachel.
Thanks, Fiona. Hello, everybody. I'm Rachel. I had a unit called Family Health Unit within the Ministry of Health and Medical Services. I'm a medical doctor by background with the public health specialist. And within the unit, basically, I manage the maternal child health, sexual reproductive health, and under that comes the immunization program. So I basically head the immunization program back home and co-chair the similar NITAG group back home with one of our CDC colleagues. So that and significantly contribute to the decision-making process. Thanks.
Thank you. Professor Jaria.
Yeah. Good morning, everyone. I'm Jarir. You can call me Itop. I'm pharmacoepidemiology and pharmacoeconomy from Universitas Gadjah Mada. And my daily also working with the Indonesian Task Advisory Group for Immunization, particularly for health economics. And then we give a lot of recommendation to the government for recommendation of the vaccine and also monitoring and evaluation of immunization program in Indonesia. Currently also working a lot for clinical trial vaccine in Indonesia. Thank you.
Thank you. And then now to our online panelists. So Professor Kulkarni.
Hello, everyone. I'm sorry that I cannot be in the meeting room personally. And thank you for inviting me to join this session. My name is Kulkarni, and I'm a pediatrician, infectious disease specialist. I am at the Faculty of Medicine, Siriraj Hospital, and I'm one of the ACIP members of Thailand.
And then Dr. Hardeep.
Thanks, Fiona. Can you hear me? Just a mic check.
Yes, all good. Thank you.
Thank you. Thanks for the invite. Hello, everyone. I'm Dr. Hardeep Sandhu. I'm at Manila, Western Pacific Regional Office of WHO. I recently joined here to support the vaccine preventable disease surveillance for the region. And also my portfolio includes introduction of new vaccines, which includes PCV also. Just as a background, I'm a physician by training. And on top of that, I've done public health practice or public health physician. I have over 35 years of experience. I've worked with the CDC Atlanta for 20 years, and then before that, multiple other international agencies. But mostly I focus on immunization program and surveillance and laboratory coordination included. Over.
Fabulous, thank you. And Yin.
Hi, everyone. I am Yin Aung. I am from UNICEF Pacific and maternal child health specialist. I'm based in Suva, Fiji. And our portfolio in this region is we are working in 14 countries. We are heavily involved in the immunization program, especially we support the Pacific Island countries' procurement of vaccines, ensuring the availability of quality vaccine through vaccine independent initiative. And also we lobby and support the governments in introducing new vaccine, including PCV vaccine.
Fabulous, thank you, Yin. And we had invited Professor Mayfong too, but I see he's not online. So I know he had a congress and he was hoping to join, but he may not have been able to come out, but just checking, no, he's not on. Okay, great, all right, no problem. So yeah, so first of all, thank you very much, and really fabulous that you have travelled and here today. And I think as Etob mentioned yesterday, and by email actually, a rare opportunity to be able to share experiences and also challenges and come together to, you know, try and figure out some solutions too, really, I think too, which is really the important bit, is how do we move forward. And so firstly, I would like to just hear from the country's perspective, where you're up to with your pneumococcal program. Very varied. Some people have introduced or just introduced recently, and some are thinking about maybe, you know, how to optimize their programs now. So everyone's quite different. So I was just wondering if you could summarize that and then think about where or what are the countries thinking about now, what's next, and what do you need then to go where you would like to go. So Tuya, I will start with you first. Thank you.
So introduction program has been started in Mongolia early 2007 with the introduction of the IPT surveillance with support of WHO in the country. So since 2007 up to the 2016, we got the baseline data on the disease burden, as well as the pneumococcal serotyping. But that data was very limited to make the decision because pneumococcal was identified in the blood. So we, through the surveillance, we detected very few amount of serotyping in the blood in the children. So then the WHO regional office as well as the country office have been supporting to extend the surveillance into the Mongolia with the technical support of MCRI. And we had the chance to get some financial support from Gavi through MCRI. So in that event actually give us the more comprehensive data on the disease burden and serotyping, which actually we, through extended surveillance, we collected data from nasopharyngeal swabs of the children hospitalized due to pneumonia in the biggest hospital of the capital city. So this is actually, we through this extended surveillance, we had the chance to look at the real data in terms of the disease burden in serotyping. And next data, which were actually contributed to make decision introduction of PCV, is the availability of access to the PCV vaccine in the market, global market. So we were actually provided the good reasonable cost of the PCV vaccine. So in this regards, the country MOH has decided to provide to procure the PCV vaccine in a phase-based manner. So before that make decision, also we got the data or information on the cost-effective analysis of PCV introduction. So these kind of data actually contributed to make a decision to introduce PCV program in the country.
And so Tuya, I think you've got a 2+1 schedule. Is that right now?
Yeah, so a definitive decision as WHO recommended, any new vaccine must be come through NITAC of the country. So the process of the introduction of PCV is gone through the NITAC. So at the NITAC, actually, we have also introduced the team of the experts who have introduced the PCV schedule, dose schedule, and then starting piloting areas, so which were approved by the NITAC and recommended to the Minister of Health. So first phase introduction of PCV 13 introduced in 2017 in the 2 districts of capital city with the 2.1 schedule. And then later, 1 year later, it's extended another 2 more districts of capital city. And then following years, actually PCV 13 has been extended throughout the country. So definitely in between, the extended surveillance has given the good data, the impact of the PCV introduction in the selected areas. Okay.
Are still Gavi eligible, or have you transitioned? Who's, yeah.
Okay, in terms of the purchasing of the PCV vaccine, the Mongolia is at that time was in the transition period of Gavi support. So, however, the Gavi was provided us to procure the Gavi price of the PCV vaccine, which was much less than the market price.
Okay, thank you, Dr. Tuya. We'll go to now Professor Anna.
The Philippines has the dubious distinction of being a high burden pneumonia country. In 2014, if I'm not mistaken, we were named as one of 15 countries contributing to 75% of the world's pneumonia burden in children. There's been a great interest in the pneumococcal vaccines. The PCVs were introduced into our program in 2015. But because of limitations in the budget, we were only able to cover 10 of 13 regions in the country. The 3 regions that were excluded were chosen based on the availability of other health services in those areas. So the thinking was that if there were more health facilities in those areas that would be excluded, kids who would not benefit from vaccination would at least have access to other health services. We started off with PCV 13 using a 3+0 schedule, and this was thought to be the most compatible with our NIP, which only covers children up to the age of 12 months. There are no booster visits scheduled. And despite the availability of the vaccine, the problem really was suboptimal coverage. So Dr. Hardeep actually showed that on the map earlier where we're colored red, and we actually have less than 60% coverage. And the numbers started to pick up only in 2018, 2019, right before the pandemic. And we all know what happened during the pandemic. So now we're back to almost zero. But in the meantime, with the establishment of our Health Technology Assessment Council and establishment of the processes, PCB 13 procurement was discontinued. We shifted to PCB 10 and still following a 3+0 schedule. The basis for the shift was the limited data that we had with serotype match together with assessments of cost effectiveness. And unfortunately, we don't really have large-scale surveillance to be able to assess the impact of this shift, even if we end up with better coverage at a certain point.
Thank you, Anna. Rachel.
Thanks, Fiona. In Fiji, we introduced PCV. It's actually a decade last month. We started in 2012, and we've got the PCV 10, and we've got the doses which are like 6, 10, and 14 weeks. And I must say, the introduction we did to surveillance and analysis into why we wanted to introduce this, and following the introduction, we did do the vaccine evaluation program with the MCRI. And the way we rolled it out was basically, we actually introduced 3 vaccines that year, and PCV was one of them, with Rota and HPV. And this was a collaborative work with the DFED, our bilateral program for that phase. And gradually, where government overtook all the budget within the 5 years. And obviously with that was the commitment by cabinet, because we had to have that cabinet paper endorsed. So that was an essential point in that context. And having said that, we at no point had to withdraw in terms of not giving PCV vaccines for our kids. But I know we did start off with GSK. And then when we moved, moved on, which was a direct purchase for us, and we managed to get a good deal on that with negotiations. But we gradually transited to UNICEF, where all our vaccines currently come through. So that just became part of the rolling system. So yeah, that's basically where we are at. And I must say we've had our all routine immunization usually have been above 90%. Though significantly was affected during the COVID, the 2 years, but yes, so I think we're doing fairly okay there.
Right, thanks, Rachel. And Ichom.
Thank you for the opportunity. I would like to announce that I'm very happy that this year we implement the PCV 13 for nationwide. And this is very strong message from the government to reduce the burden disease of pneumonia, especially in children in Indonesia. But actually PCV 13 has been implemented in Indonesia since 2017. But that's a sort of like a demonstration project in one province in Indonesia. But before the implementation, I think there are a few studies done in Indonesia to show about the pneumococcal carriage among the children. And then when they started the implementation of PCV 13, Indonesia is still on the transition between from the low-income countries to the middle-income countries, and now. But we still get the UNICEF prize, and the commitment for the UNICEF and the Gavi are still from 2017 until 2026. So meaning that we still have a few years to come with using the UNICEF prize. And then 2018 and 2019 introduced it again into the another islands and another provinces. And actually, we are going to have around half of the provinces in Indonesia in 2020 and then 2021. But unfortunately, expanding of this immunization of the PCV not happen because the pandemic, and then a lot of budget of the government relocate to the COVID. But this year we implemented a nationwide, and then still using the UNICEF price. The schedule is 2+1 from 2 months, 3 months, and then also 12 months. We use the PCV13. Even though the PCV13 is only covered around 60% from the our cause of pneumonia, but I think this is going to be have an impact in children. What the problem here is we have the first dose and the second dose is very high coverage, because that's implemented together with other EP program, such as like a DPT1 and DPT2. But I think the booster of 12 months is quite challenging. Why? Because we have no other vaccine given on the schedule on the 12 months. That's why I discussed it with MCRI. Can we move to the 12 months into the 9 months? Because we have MR in the 9 months of age. So it's easy probably also for the parents to bring them.
Level 1, private clinics, 48 Flemington Road, allergy. Met East Building, level 1, 48 Flemington Road, private clinics, allergy.
Yeah. So that's why I think it's a need to have some evaluation again, you know, to have better coverage, whether this is could change from the 12 to the 9 months of age. Yeah.
Right in saying that the cost and the budget impact was probably some of the issues as to, and your massive birth cohort, obviously, and having, you know, competing priorities. Is that the challenges, I guess, in terms of introducing it? I suppose it's a very complicated situation. Yeah, ETOB. Sorry, yeah.
Yeah. I mean, we conduct the study of the for the PCV13 for the nationwide, and then the show is cost saving for our setting. I think this is because we have a very high burden of the pneumonia, and then cost hospitalization is really a lot. So that's to show the policymaker that the intervention of the vaccine, I think that's shown also by the Professor Jit this morning, is really cost effective. And then in terms of the budget, we calculated from the budget impact perspective of the government. This is we calculate this around half until 1% from the total budget of health. So I think this is because I think if we calculate the budget from the central government perspective, probably it's a bit low. But when we calculate the perspective budget from the provincial and district level, that's quite higher. That's why sometimes we need to have gradually implementation of the vaccine, because the district government need to prepare the fiscal year for the next year. But for the PCV, we started already since June for implementation, and then now it's almost probably until early next year we can have all nationwide implementation.
That's great, wonderful news. And Professor Kulkarni.
Thank you. Thailand is a bit different because we are the middle income and therefore are not we are not eligible for CRE support. And that's why we have to do like self-pay, and we don't get the special price. So everything has to be competing with other priorities. And now at the current situation, because of the COVID-19, our pilot program on the implementation has been delayed, but eventually we successfully implemented in as a pilot in one province. And with that, we are hoping that we can have the successful and achieve our target. At the moment, from the report we received from the province implemented the vaccine, we found a very high acceptance among parents, more than 96%, and the healthcare professionals accept the vaccine and put it into their routine immunization program service very, very smoothly. We have no problem with the cold chain, the storage, and all other systems. Moreover, we do not have any problem with the AEFI. However, this pilot program just started early 2022, so it will take a bit to see the impact. And we are hoping that following this pilot program, we should be able to expand our implementation nationwide. This is very important because the universal coverage system of Thailand, we are not allowed to do the co-payment, which actually is all or none. You know, if we are to give the expensive vaccine, it means all the country have to receive it has to be available for everyone in the country, the whole country. We cannot do co-payment, and this is obstacles a lot for expensive vaccine, although the ACIP highly endorsed, and the system to put into the EPI budget is very complicated. We have to compete with several other priorities, as said. And finally, one of the issues that highly impact on the decision making is the social pressure. In our setting, I believe it's in every setting, but our setting is exceptional, and that not just the CEA that proves the cost saving, that's not enough. Budget burden to the whole budget of universal coverage, not just enough. That one is important as well, but other push, you know, the external push, social, political, and several other stakeholders' commitment are very important to really push it into the EPI program. And finally, the schedule that we are using is 2+1, and in the pilot program we use PCV10 because they won the bidding because they have a lower price. And amazingly, we found that PCV13 can reduce a lot of price, however, still cannot win in the bidding. So they're looking forward that perhaps next round they would be able to get in. And because of the governmental procurement system, we are not able to do the multi-year commitment for procurement. So this is very, very difficult. It makes the vaccine supply unsecured, but this one is so difficult to fix because it's the law. So many people try to fix that, but it's very difficult. So eventually, what we want is the good price from the vaccine. So we're very happy. Right now, the Serum Institute of India has submitted their dossier for FDA approval. And we are hoping that with their approval, we can use it in the EPI program, and further in the next pilot program, we are hoping that we would be able to, implement it nationwide, which usually after the pilot program, it takes about 4 to 5 years. Like HPV vaccine, we piloted, and 5 years later, we were able to implement nationwide. But for this vaccine, we hope that it's shorter. We cannot wait another 5 years. So we really hope we can push it faster. So the price is the crucial, and as well as the other social and political pressure are very important. Thank you.
Great, thanks for that, Kulkanya. And now we'll go to Yin Yin. We've heard from Rachel and Fiji about what Fiji's been doing, but the other countries, if you could let us know, Yin Yin.
Thank you, Fiona. In the region, UNICEF covers 14 countries, and all the countries, there's really good news that all the countries has introduced PCV vaccine. And out of the 14 countries, 8 countries introduced only last year, 2021 and 2022. So it's quite early stage to say that what is the coverage rate, because coverage rate is just started, program just started. But for other countries in the region, also have the kind of, Rachel has already alluded that the coverage rate in Fiji is very high. But other countries, what we found recent years in North Pacific, Palau, or RMI and FSM, the PCV3 is kind of low coverage, less than 80%. Some countries is around 60, 70%. So with the COVID pandemic and the routine services being affected, the coverage has kind of reduced in some of the countries. But some of the countries can maintain the high coverage. So in this region, kind of some of the country, half of the countries using the 2+1 schedule, but half of the countries using the 6 weeks, 10 weeks, 14 weeks schedule. So this is in summary what is the update from this region. So kind of some countries are in early stages. And in terms of using the vaccine type, all the countries are using PCV13, and except Fiji using PCV10. And I think that Fiji has really did a wonderful job in using the PCV10 and save a lot of money. And most of the countries in the Pacific are middle-income countries, except Solomon Islands, Kiribati, and Vanuatu. So the price, the country has to really invest a lot of money in the vaccine. So I want to stop here.
Thank you, Yin Yin, for that update. Dr. Hardeep, would you like to add anything? You did summarise this morning, but if you'd like to add anything to what you said this morning for your talk, please go ahead, just where countries are up to.
Not much to add here, but just to say that these are real world issues which have been highlighted, and we face them every time we talking about introducing any new vaccine, whether it's PCV, HPV, or any other, or those which are coming down the pipe. So I think that's all I would like to say for now. Thanks.
Okay, no problem. So there's a few things that have come up, and Kulkanya and Yin Yin have talked about the Pneumococcal, which is the Serum Institute's vaccine, which is a cheaper vaccine, and I provided the cost of that in my talk. And so that's a pre-qualified vaccine, pre-qualified by WHO and sort of ready and available. So I'm just wondering again from the countries that are not using the vaccine, so Etob, Anna and Tuya, whether there's considerations about changing at some stage, or whether you've done cost effectiveness analyses, or where you're up to and what your thoughts are about that. So maybe we'll start from Tuya.
Yeah, definitely. After introduction of the PCV vaccine, which has been procured with the government fund, so the researchers and health people have been asked, requested by the Minister of Finance and non-health people that we have to really show the impact of PCV. So whether it's the disease burden is reduced, if reduce it, how much, and what's the cost benefit for nationwide as well as the family level. So in this regard, we really need to collect the data. What's the real cost analysis or cost effectiveness of the PCV introduction in the country? So we are planning to do so.
Anna?
The shift from PCP 13 to PCP 10 was actually informed by a cost effectiveness analysis that was undertaken by our Health Technology Assessment Council. And I would expect that since the other lower cost PCBs are already, is actually already licensed in our country, that there will probably be another round of assessments very soon, especially with the pressure brought on by reduced health budgets. I think the problem will really be more of who will initiate that process. I'm not sure whether the program needs to be the one to do that, or whether outside stakeholders, like maybe the professional medical societies, will have to think about doing that. And that's a substantial barrier, because when we look at other requirements for a request for assessment, a lot of the documentation needs to come from the professional medical societies. And I don't think we're really situated to be able to do that kind of preliminary analysis. So those are some of the things that we have to work with the HTA on, so that it becomes less difficult to get all of these processes done.
And Etom.
Yeah. We also did a study of the cost effectiveness analysis between PCP 10 and PCP 13 using the UNICEF price. But we see not significantly different, meaning that even though the cost effectiveness per Kali gain is still a little bit higher in PCP 10 compared to PCP 13. I think that's because the match of the serotype from the PCP 10 to the PCP 13 may be more matching to our burden. So that can reduce more cases in Indonesia than the PCP 10. So that's the cost effectiveness a little bit higher on PCP 10 than PCP 13. But the most problem is if we change it, the price from UNICEF price into the market price now. Or we also do it with the PAHO price. The increasing is almost 5 times higher, the cost effectiveness. So again, still PCP 13 is still a little bit lower compared to PCP 10. So I don't think that probably easy to change, in terms of the operational and then immunization. But what I like to highlight probably based on the information that we received it in the last 2 days, that may not different on the effectiveness from 2+1 and 1+1. So I think that's we need to prepare based on the data that I have from our cost effectiveness analysis. So after a couple of years, we need to prepare to not to use UNICEF price in Indonesia. So meaning that the budget impact will be increasing. So if we already have the cost effectiveness analysis for the 1+1, I think that's will be good to inform the decision maker from now. When we switch it to non-Gavi price, so we can have information how cost effective is it, and then also how big the budget impact. And then also in terms of the data that I have it from a colleague who would conduct some study in one particular province in Indonesia after implementation of PZV 13, after 2 years, compare between the one that vaccinated, the one with not vaccinated, the difference of the serotypes is not so much. Only serotype 4A and 4B that lower or more significantly compared in the vaccinated group compared to non-vaccinated. So this is also wonder, I think, based on data from Vietnam, they presented this morning. If we need to change this into 1+1, do we need to have first the herd immunity in the in that places before we change it to 1+1? Based on this data, how long that actually we need to wait until we switch it to 1+1? I think the idea is we have several provinces. It's been implemented this year almost 5 years. So that could be kind of a cluster randomization for those islands for 1+1, and the other island who started just this year or next year, that could be also as a control for 2+1. That's the idea that probably we can work on Indonesia, and also to look at the long-term surveillance to see the impact of the 2+1 and then 1+1. Yeah, thank you.
Is then the surveillance needs as well. So to be able to figure out, you've said, well, firstly, how to work out, when herd immunity. So how, you'll need some sort of data, whether it's invasive disease or carriage data to sort of figure that out. As Kim has mentioned earlier, that the UK is the only country that's switched, and because of COVID, all the data is a bit odd at the moment, so we don't really know the impact, and what happens in the UK may not, obviously that would be reassuring, but in different settings it might be, a little bit different. And so it's really the surveillance needs, and so Toya, there was an enormous amount of building capacity and surveillance in Mongolia with your phased introduction and things. So what's happening now in terms of your surveillance too, to be able to figure out, well, you've done your impact, but, ongoing, is your government investing in that, or are you still doing surveillance, or, how are you going to look at non-vaccine types?
I think the carryover IPD surveillance, it's, I would say it's costly. And also it's actually in the process to get the some good data. So our extended surveillance on the pneumococcal disease among the children is still continuing with the support of Gavi Fund, with the technical cooperation with the MCRI. But however, through this surveillance, we are trying to build up strengthening the government capacity. We're focusing on the more health sector strengthening approach through actually sharing the knowledge, experience, or challenges with the doctors, nurses working at the hospital or project sites, and also through sharing the data collected through our surveillance, and having monthly meeting or weekly meeting and providing the feedback. So in such a way, we are trying to strengthen the existing surveillance funded by or run by the government, but still, in terms of laboratory, still the country needs some support, particularly bacteriological lab. It's weak. We cannot really detect pneumococcal. It's serotyping in the country. So it's all done in overseas, particularly the MCRI. So in this area, we really need to support in the future.
And is it mainly invasive disease surveillance that you're doing now, or are you doing pneumonia surveillance or carriage studies? Like what actual surveillance now are you planning or would like to do or are doing at the moment?
Besides continuing the hospital surveillance, first of all, we have done the carriage survey pre-introduction of PCV, as well as the post-introduction PCV. So this year we have collected the post PCV carriage survey. So we're going to send the samples again to MCRI lab to find out the what happened after introduction of PCV. So the carriage survey, maybe we need to have one more carriage survey in near future if fund is available, to control or to see the result of the PCV impact on herd immunity in the country.
Great, okay. And Professor Anna, just in terms of the surveillance and
We have a passive surveillance system in place. It's piggybacked on the antimicrobial resistance surveillance program. So that one is pretty well established. And for all of the samples coming from sentinel sites that grow out strep pneumo, those are serotyped. So we have an idea of what we have circulating. The numbers are very small, about 150 to 200 samples that we collect yearly. And based on that, that particular data set informed the choice or the recommendation to shift from 30 to 10. So I would expect that this would be the mechanism over time that we would be using to try to guide decisions regarding the choice of PCBs in the program. We've never had a carriage survey, this is really coming from the fact that we don't have a lot of laboratory support outside of the urban centers. However, I am thinking that coming from this COVID experience where we suddenly have all sorts of molecular diagnostic laboratories that were established to support the COVID response, maybe that could be utilized to supplement, or rather to work on not just COVID, but all of these other pathogens for which molecular diagnostics can also be used.
It sounds like you've got invasive disease surveillance, like quite a number of isolates you get every year, like to figure out what's the distribution of serotypes.
So I'm having a little bit of trouble answering that because it's not actually intended to be invasive disease surveillance. So it was actually ARSP. And then whenever you get a strep pneumo sample, then that's part of it. So I would not call it a specific program looking at strep pneumo. It's just that it's picked up because of these other programs that are in place.
Yep. And Rachel, in terms of your surveillance systems and how you're, monitoring what's going on.
Thanks, Fiona. So basically, I mean, one of the things that has been happening over the past years has been strengthening the vaccine preventable disease unit within our CDC team. And that also meant strengthening the lab capacity as well. So while a bit can be done in the country, but we very closely work with Doughty in terms of getting things across here as well. So the surveillance is ongoing. since the introduction. And yeah, as you know, the vaccine evaluation, the carriage surveys, the studies, etc., that were conducted, and then currently, as we speak, the surveillance keeps going.
Great. Etop, did you want to add anything? But
Yeah.
yeah.
I think similar. I think we need to still strengthening our surveillance in Indonesia. Since we implement nationwide, I think the surveillance need to be in place. Again, similar with colleague from Philippines, in the lab capacity, I think since we have a lot of lab capacity for COVID, I think this is also will be very useful to conduct surveillance in the many various islands in Indonesia. I think we don't have currently systematically how to surveillance of the after and before PCV implementation. But as I mentioned, there were some studies conducted by academics, hospital, together with collaborators to see the carriage of pneumococcal among the children. But we have the government passively collecting data every 5 years. I think the next year will be new data come up about the cases hospitalized pneumonia that's in every provinces. So that's just 5 years of data collection. And in terms of the pneumococcal invasive diseases, we have only one data to show the PID dropped in the islands of the implementation in 2017. When we see the data on 2018 and 19, the hospitalization of pneumonia in those islands are dropped very low. This is the only data. Unfortunately, this is not published, but I think this data show also impact of the hospitalization of pneumonia. I think this, I suggest not only for the carriage, but also collecting data, hospitalized severity of pneumonia. It is important to see the impact of the PCV implementation.
Okay, great. And Kulkanya.
Sorry, I'm muted. Well, the surveillance of serotype is not very widely systematically performed in the country, but we have the national lab surveillance where is the passive acceptance of the samples of the invasive pneumococcal disease isolates that sent to the central lab in the national lab. And they can collectively serotype periodically. And we have like small scale studies that have like long-term continuously monitor the serotype of the invasive isolates in, say, in Bangkok and in some other province in a few places, but not very highly covering the whole country. However, from the data from several studies here and there, the small jigsaws, we can form the idea that 19A is like around 5% of all the data available from here and there, except for in Bangkok and Vicinity. We found that the percentage of 19A among invasive pneumococcal isolates is almost like about a quarter, 20%, or even higher in some certain area. but Bangkok is the capital and is the place where is the highest uptake of PCV, because we have had that PCV available in the private hospital, private market, where the parents can self-pay and get PCV to their children by themselves. And I think this could be the pressure, the selective pressure caused by some vaccinations coverage in big city like Bangkok. So that's why I have said that I'm very happy with the Serum Institute PCV10 that have 19A included in their vaccine, and as well as the 6A. So I think if the Pneumococcal come to be become available, then I think it will be more relevant to the situation in Thailand. However, in the general picture, at the moment, not just excluding Bangkok, then PCV10 or PCV13 may not be that much difference. In terms of continuation of the monitoring of the serotype and vaccine types, we are in the process that we need to set up along with the pilot program that I mentioned earlier, that in one province we have to monitor the invasive pneumococcal disease breakthrough and trying to do the cost effective analysis, the efficacy analysis, perhaps with the nearby province. So I hope that we are able to monitor efficiently. Right now it's in the process of setting up the laboratory monitoring system. Thank you.
Thanks, Kanya. Just on that, you mentioned the interest based on the serotypes in Thailand, and Pneumococcal being a good fit, and obviously the price is more attractive too, I guess. But though there isn't, and whether there's interest in, and I think you mentioned it earlier, potentially a 2-dose schedule as well. And so what would you need to know? I mean, we've got three-dose data that Kim showed this morning from Prevnar and the GSK vaccines, but there's not that 2-dose clinical trial from Pneumococcal. There's 3-dose, of course, and it's been pre-qualified, it's safe, and the immunogenicity with 3 doses is, good. So just wondering from your discussions with colleagues and yourself, what else do you would like to, is there anything else that you would need regarding a 2-dose schedule for Thailand?
Yes, at this moment, the 2-dose schedule 1+1 is not well accepted in most of the advisory members because of the lack of data that you mentioned. So what we need is the data, the clinical trials, particularly we are thinking about, and you have involved, and very much appreciate on your ideas and support on we perhaps should implement the catch-up program of 1+1 and implement further on 1+1. And obviously, if we are to use Pneumococcal, we will need the data, perhaps an RCT, a separate clinical trial that can answer to the questions. But I think at the moment, if we are to escalate our PCV implementation nationwide, it will be 2+1 until we do have the data of 1+1 by Pneumococcal. Then we can do 1+1. But otherwise, 1+1 with catch-up, perhaps if we are to do it, we will need to use the currently available data meaning that with not pneumococcal. So I think our practical answer at this moment that we mostly are foreseeing is that we are going to implement 2+1 with pneumococcal nationwide when scale up nationwide. And in parallel, we should try to generate the data of 1+1 and when using pneumococcal. And when these data are available, then we can, change the schedule from 2+1 to 1+1. I think that would be the way that I foresee. Okay.
Mhm. Thank you. And we've only got a few minutes left, actually, and I don't know if there's any questions, no questions in the Q&A. If anyone would like to add anything, or Dr. Hardeep, if you'd like to add, or any of the panelists or any other questions from the audience, please, or Mark or Natalie, would like to say anything? Are you, Tom? Yeah.
Yeah. I just want to highlight about surveillance. I mean, in the country like Indonesia, we have a lot of things to do surveillance. Is there any data from other country that combine all this surveillance into one system? Example like Rota and then Pneumococcal, what others diseases. I mean, this maybe make it more efficient in surveillance system. The data also could be related each other, because sometimes when I see the children sick in the in the hospital, they not only come because diarrhea, they not only come because pneumonia, but combination diarrhea and pneumonia is very common. Yeah.
I might ask Dr. Hardeep if he'd like to, because you mentioned this morning about integrating surveillance systems, Dr. Hardeep. So I'm wondering if you'd like to contribute to answering that one.
Sure, Fiona. I think this is a very important time and area that there are so many multiple vertical programs going on, and there are duplications, and then because of the way the budget comes to a country or to a lab, they cannot use a particular machine, even if that machine can perform surveillance for other diseases, but you cannot do it because the budget has come from a particular head. So we at Wipro, as I mentioned in my framework and as an extension of the vision of an integrated, comprehensive VPD surveillance system, we have started to think about it. And actually, that's my main role now at Wipro for my time here, that we will define our vision and a roadmap for such comprehensive integrated system. But mind you, everything cannot be integrated. Certain special specimens have to be shipped specifically. The case definitions cannot be combined. But I mentioned about the platforms, the dengue and the measles platform, the rash fever platform, the overall diarrhea. We have a program going on, the global pediatric diarrhea surveillance program, in which we are going beyond rotavirus. Since the diarrhea specimen is coming anyway, why not test it for other? So your point, Doctor, is very valid, that we should start thinking about it. And the global agencies like ours can sort of sit and think through it and propose and sort of convene and then facilitate those kind of things. And we are going to start very soon doing that. So that's it, Fiona, on this question. But I have just few more comments just being here, but I'll wait for your signal for that. Over.
Oh, no, please go ahead. Yeah.
Okay, no, thank you. Now, this is very important and very informative discussion for me, especially the country perspective. And I will summarize it very quickly, that the UN's role in all this effort is to be facilitative, to be catalyst, and then find where there is a choice or where there is an opportunity, we can bring in the startup budget. Because sometimes the government will not make a decision. They're not convinced that you're starting something new, we're not putting in the money. But if WHO or other international public health agencies, they come in and then they provide a startup budget, show the proof of principles, many times the governments will come up and will say, oh yes, we feel this is a good use of our money. We will do it since an international agency is endorsing it, and also is happy to get it started. So that's one point I wanted to make, that we are there facilitated, but at the end of the day, the countries have to take the initiative. And in that sense, WHO usually supports the NITAGs, and we give them every information they demand, and we sort of provide them proactively all the WHO recommendations, which WHO comes up very periodically, the position papers, which I put it in my presentation for pneumococcal specialists, especially, and also the list of pre-qualified vaccine, because that triggers a lot of things. Once you have a pre-qualified vaccine, the countries who are Gavi eligible, they can go for there. If the country is purchasing through UNICEF, which most of countries are, they can use that pre-qualified trigger to purchase bulk and have a competitive price through UNICEF and be more cost effective. The other point I want to make is that safety profile of vaccine. We time and again advocate and push and facilitate the AEFI surveillance, because we have seen in countries many times one incident, even if it is not really related to vaccine, but the media picks it up, you have damaging effect for years, if not sometime decades. So that's very important, that the safety profile is established and is communicated in a proper way. Enough said on the econ side of things, that the cost effectiveness is key. Ministry of Health cannot go to the Ministry of Finance if they don't speak that language of how economists talk. You have to bridge that gap. That interface has to work for any new budget to be released. Third part I wanted to say is the surveillance. WHO is key facilitator for surveillance for invasive bacterial VPDs. And we are trying hard, and we have a plan, we make a framework, but the thing that breaks it is the budget. No international agency, and there are no international big initiatives which support bacterial and invasive bacterial diseases, which are VPDs, surveillance. So we have limited budget, we try to do it, and we have good example in Mongolia where we are supporting and we're getting good results, but there is limited budget. So that's where our hands are tied. But the surveillance is a key element in the new vaccine introduction. And then we operate through local agencies or local institutions, the local or the regional WHO collaborating centers. They play a key role in helping establish those sort of things. And communication, again, last piece, that communication around new vaccine introduction is key from beginning to introduction and later on for AEFI, for communication with the politicians, with the media, and with the mothers, that if you have a diarrhea vaccine, that doesn't mean your total diarrhea will be gone. Kid can still have diarrhea. It's a diarrhea vaccine, we call it for simplicity, because mothers won't understand rota and norovirus or any other viruses. So we have to be very clear on communication for the new vaccines to work. Lastly, innovation. The new delivery technologies, the microneedle patches and others, which cut down the cost and sometimes are easier to administer. That's one area which WHO and other public health agencies are working on. They will make the introduction of new vaccines easier. And then the new schedules, like the example I gave for the HPV vaccination, that SAGE has recently come up with the recommendation that you can have HPV vaccine as single dose and is equally effective, particularly in the younger age group girls. So starting with that, many countries have in the region, in Western Pacific regions, are encouraged because it cuts immediately the cost of vaccine at least to half, and along with that, the operational cost also. So you can have one and done thing for HPV if you have a one dose schedule, and if you can catch the girls earlier. So there are many places where we can sort of come in and converge, and I wanted to just highlight these points. Thanks for the opportunity, Farah.
Fantastic. Thank you so much, Dr. Sandeep. And on that note, we must draw our panel to a close. 15. But I would like to everybody from the screen, Professor Kulkanya, Dr. Sandeep, Dr. Toya, Professor Anna, Dr. Rachel, and Professor Etob for being very generous with your, your comments and your solutions and all the things that you've, for the whole symposium that we've had, the forum for the last couple of days. So thank you very much. We have lunch again up the back. We'll come back at 2 o'clock, and this afternoon is with Paul and Rachel. Oh, no, Paul and Anna. And Anna, who will be chairing this afternoon the immunology session. So that's our this afternoon at 2 o'clock. So we'll see you back here at 2. Thank you very much.